that's also theoretical. And so it's theoretical that, so you do need the withdrawal of progestin in order to have your breast milk come in for lactogenesis and to achieve good milk production. Theoretically, if you have a high dose progestin device, that you could decrease your breast milk, but there's no evidence that that actually occurs. When you talk to your patients, you will have to talk about that theoretical risk and whether their risk is, or whether they rather take the risk of unintended pregnancy versus coming back in to have their device placed. But I think in the context of looking at evidence, most women are willing to have the device placed immediately postpartum.
I usually, along those lines, I think it's really important whenever you're trying to institute an immediate postpartum LARC program into a hospital setting, it's really important that you reach out and include all the stakeholders, including your lactation services as well, because it's unhelpful to the patient if Dr. Beasley and I are counseling them in one way and then the lactation service provider comes in and counsels them in a different way as well. And that could be about lots of different things. It could be about antihistamines, it could be about anything. But in particular, the most kind of pushback that I've gotten in regards to postpartum LARCs tends to be from the Nexplanon in regards to breastfeeding for that theoretical risk. My personal experience, which of course is anecdotal, is that I haven't had any patients come back and complain about not being able to breastfeed that I placed an Nexplanon in. When I speak to our lactation service or I speak to the patients, once again, like most things in medicine, it's a risk-benefit ratio. And I try to explain, not to sound too snarky, but another thing that also really affects breastfeeding is getting pregnant again. And so those are all things to think about.
And then quickly to address, I think you were talking about lost IUD strings. Okay, so there is a risk of having, when you place the IUDs, especially during a C-section, that the strings will not migrate through the cervix. When someone comes immediately back, we do an ultrasound to make sure that the IUD is still in place, because as Dr. Bump said, there is an increased risk of expulsion. But I have found that they are actually not difficult to remove, and that most of the resources and ways that you would do for an IUD where you couldn't have strings, you are easily able to retrieve it most of the time with like uterine forceps versus having to use other things like an IUD hook or alligator forceps.
Hi, my name is Paula Meyer. I'm from Chicago, and I'm a human milk researcher. And I really love the tone of the way you're presenting this, this work, because it's so good. But I want to just question or add something that maybe if you could respond to. Our work is focusing on the first 2 weeks post-birth in mothers who have premature babies and are breast pump dependent. And as I'm sure you're all aware, the studies that have really been done, although they're rated moderate to low quality, have really excluded mothers who deliver less than 37 weeks and mothers who are breast pump dependent. Our work on secretory activation in these mothers is that it's delayed. So my question is, I think from a biologic perspective, this is a group of women that are at greater risk because of the slow fall in progesterone that we see in them, and probably some of the pump-dependent things as well, because we've actually measured biomarkers in the milk as a measure of secretory activation. So I guess my question is, what I am concerned about is the data that exists for the healthy population generalized to this population, and if you have this as an issue, how do you handle it? I love the idea that you at least let mothers know it's a theoretical risk and they can make that decision, which I think is my position. But I've worked with many obstetricians that don't want to even share that information with mothers, including the mothers who have babies in the NICU that are premature.
I think it's really important, as we talked about, that this is a continuing conversation. So as we introduce the conversation, we are hoping that all our women are going to achieve a term pregnancy and while we're talking about these. But if circumstances change, I think it's really important to also change the conversation and say, remember how we talked about this, remember how we talked about this. And if you have a woman who has a child that's in the NICU or is pump dependent, that may be someone who says, that's not a risk I'm willing to take. And then I think that there would really be a role for partnerships first let's remember, for like implants, you don't need to be an OB-GYN to put them in. They're very easy to put in. So there's roles for lots of other providers to be able to put the contraception in when they feel like it's time.
I would also add that once again, I think it's patient dependent. If I have a patient who has a preemie because she just had an eclamptic seizure versus a patient who had a preemie because the baby needed to be delivered for a fetal issue, then I'm going to counsel those patients a little bit differently. I'm going to tell them both the exact same information, but for the patient who's just had a major maternal issue, and if she really thinks that she may have, become sexually active before she makes that 6-week postpartum, then we may talk about the risks and benefits of having donated human breast milk versus the decreased risk of her lactation, and what that could mean for the consequences for her own health. So I think it's really important to individualize people's counseling as well, but I think those are all really good points.
Are you aware, I just see there's not anyone here, are you aware, I know of one pilot project, and it's something we're embarking upon with our partners in family planning, is instead of the 6-week visit for this population, these are mothers who are there with their babies for a long time. So this could be something that's a 3-week or a 4-week period. So it's not like we lose them to follow up. So I think that's another thing I would have you think about. Are you aware of programs of that nature?
So I know that ACOG in general is advocating that we really do need to touch our patients earlier than 6 weeks. And so there's lots of different, suggestions about how to get that done, because there's a lot of pressure on physicians to keep up their volume and keep up their RVUs as well. And so it's competing time to add yet another postpartum visit. But there certainly are ways to do that. But I would say that the patient who's unlikely to show up at the 6-week is probably just as unlikely to show up at the 3-week. And so I've certainly, unfortunately, had lots of patients that have had babies in the NICU, and while they may be in the hospital for months, those mothers are under such stress that sometimes they miss their appointments too, even though they're only one building away from me. And so I don't know that that the risk for them not showing up at 3 weeks is any better than the risk not showing up at 6.
And then I know we're running out of time, but I will say the evidence does show that for women who are interested in LARCs, if they do not get it postpartum, then they are less likely to get it in the future.
Sorry, can I ask the last question?
Yes, one more question because we're at the 2-minute mark.
Yeah, so I'm so pleased that you guys are talking about this today. I was really excited to see it on the program. We're really interested in this in Illinois as well, and we, in addition to our opioid initiative that we launched this last year, we launched an immediate postpartum LARC or IPLARC initiative, and we are expanding it. We started in 16 hospitals, and we're expanding it to the rest of the hospitals in the state this spring. Do you have, and one of the things that it's been really clear as we've done this statewide is that hospitals who are trying to work on this one-off and implement it at their own hospital, it's a lot, and it's a lot of trying to get people to change perspective, and you're trying to figure out this billing and coding and getting the reimbursement. And we found that there's a lot of strength in numbers, and that hospitals working together on it. So these 16 hospitals were able to implement, our go-live date was March, and so we've had 100% of our teams have been able to implement within 9 months. And I think that I'm just wondering what kind of supports there are to have hospitals kind of work together on this. We also have found that a key players meeting where we came in with an expert from the outside and came into the hospital and had kind of all the key people have a 2-hour meeting in one room. That seemed to really jumpstart for a lot of our teams that were seeing barriers. And the other thing I think that we're trying to do is make sure that we're discussing with the outpatient as well around this idea of patient-centered comprehensive counseling, and really making sure that patients are getting all their options discussed and trying to be really respectful, like that patient who brought up, really thinking about what your patient's goals are and what the options are. And we're really, the focus of the initiative is reducing barriers to access. Not everyone should get an IPLARC. Yeah. It's really about, there are real barriers to this really important option. And so, but it definitely takes both inpatient, outpatient, and it seems like it takes hospitals working together.
So I completely agree with you. And where we're at in Texas, to my knowledge, and there may be other things going on that I'm not aware of, but so the Department of Health and Human Services has a LARC stakeholder meeting, and that happens every other month. So a lot of different stakeholders across the state get together and talk about what their challenges and what their solutions have been. I know that with my work with the March of Dimes, that they also have done quite a bit of work as far as getting all. For me, it would be in the Houston area, talking about getting all the different hospitals to the table, talking about, once again, sharing best practices and talking about different barriers to overcome and sharing that information. And what's nice at that meeting, at least, is it's not just hospitals, it's not just providers, but it's also the different insurance providers as well. So the MCOs and things like that are at that meeting too, and so they can help talk about reimbursement challenges and how to code things properly or get things through proper channels. So I definitely think that that's worthwhile from a statewide system. I think we could definitely work on that, like what it sounds like you guys have done.
We have, there's some really good toolkits out there, because another thing that works is to use Don't Reinvent the Wheel around EMR tools. There's a lot of great dot phrases. So our toolkit is available at the ilpqc.org, and then South Carolina has a really awesome toolkit. And then ACOG has a lot of resources through their LARC page. And there's also an ACOG committee opinion. So if you have like resistant providers, there's an ACOG committee opinion that recommends that all women should be counseled.
And one of the things that I would mention too is that the things that are important if you're thinking about doing this at your hospital is, like I mentioned before, is, you know, have a champion that's going to go out and be willing to put in the effort and march to get the message out to not only just OB providers, whether those are midwives or MDs, but also make sure that you know, do an in-service with your nursing staff on L&D, because this is kind of a new thing for them too. And you know, there are a lot of things that come up from those type of conversations that I wouldn't have thought about. We're having to revamp our consent process because some of the questions that some of the nurses asked me when I gave the in-service on this. So it's really important. The more conversation you can have, I think the more complete it'll be.
And we found ACOG was willing to come to Illinois and did a series of trainings, provider trainings. So we did regional trainings for postpartum IUD placement, immediate postpartum IUD placement. And then for the contraceptive implant, they'll actually come to your hospital and do trainings with your providers.
Thank you.
Thank you to our speakers for their time. We're slightly over, so unfortunately we're going to have to end and bring up the next group of speakers. But thank you for your attention, and join me in thanking our speakers for their work.
All right, well, I have the pleasure of introducing our next speaker. We're going to shift gears a little bit. Over the past couple of years, we've started to rethink the postpartum period. Dr. Haywood Brown, past president of ACOG, established a task force to look at postpartum care, knowing that many women who have adverse outcomes and have maternal death after delivery, some of those occur after 42 days, and that there may be some windows in the postpartum period that we're missing because patients don't come in for care. We're missing early detection of depression and other interventions that may be helpful for these women. So in May of 2018, the committee opinion was released by ACOG, Optimizing Postpartum Care, and our next speaker is Dr. George McCones, who will be speaking on that topic. Dr. McCones is the chair of the Department of OB-GYN at Washington University and the Mitchell and Elaine Yenow Professor in the department. He also serves as the fellowship director for the MFM fellowship at WashU as well. He completed his doctorate in medicine at Jefferson Medical College in 1988 and Master's of Science in Clinical Epidemiology at University of Pennsylvania in 1996. He did his residency in obstetrics and gynecology at Pennsylvania Hospital in 1992 and subsequent fellowships in maternal fetal medicine at Thomas Jefferson in 1994 and clinical epidemiology at the University of Pennsylvania in 1996. On a side note, he was my oral board examiner for MFM. Speaking of that terrifying event before, and I made it.
I thought I was going to say, was that the first time you took boards, but that would be a terrible thing to say. Sorry. Well, thanks for the nice introduction. Wow, it makes me feel incredibly old. But I'm glad to be here with you all today. So again, thanks for the invitation.
work on slides.
Okay. Well, I think as Pat mentioned, the postpartum visit, I think, is something that has been somewhat ignored over the years. And certainly, back when I was training, as Pat mentioned, back in the late 80s and early 90s, the postpartum visit was really something that was viewed as sort of the end of an episode of health or an episode of care, rather than a sort of a beginning. And if I had to sum up what we're going to be talking about today, it would be just that the focus now should be on looking at a postpartum visit as sort of a new beginning for a woman rather than the end of a pregnancy. And I will say that in MFM, we're probably the worst at that, because when we're done with the pregnancy and delivery is finished, we just hand patients back to their generalist. And I would give Haywood Brown a lot of credit as an MFM for taking this on, because it's probably something that many of us have not focused on in the way that we should, much like preconception care, which I think also has gotten short shrift in the past. So over the next maybe 40 minutes or so, we're going to do a little bit of a whirlwind tour of the new paradigm for postpartum care that Pat alluded to, that was really championed by Haywood Brown. We're going to talk about some of the components of postpartum care in this sort of newish model. And then along the way, maybe a little bit about implementation. And the implementation piece, I think, is complicated, because the new guidelines really call for, really a bit more, I don't want to say work, because it's not work, because it's taking care of women, but again, doing some additional screening and talking about things that perhaps traditionally we haven't really done. So some things that we're not going to talk about today, fortunately for all of us, we're not going to talk about coding or billing and reimbursement. Those are separate issues that other people can talk about perhaps over a large cocktail later tonight. I know there's been a lot of focus on maternal mortality today, so I'm not going to really get into that at all, although part of the genesis for the focus on postpartum care was the fact, as Pat alluded to, that a lot of maternal deaths were happening in that period. Certainly, we need to be advocates for work and paid leave for our patients, but again, we're not going to get into that too much. How we should train our providers and people in our office, we're not going to talk about, or research directions, of which there are many. Okay, so why is it focused? I think I touched on this a little bit already, but postpartum care, I think, had really been ignored in the past. And back when I was training, postpartum care was see if a patient needs a pap smear and talk about contraception, and that was it. But there's a lot more to it than just that, because it sets the stage for a woman's long-term health and well-being, and it's a great opportunity to set up a woman for future health success, if you will. There's also fragmentation between maternal and pediatric care, and I do think that there are some opportunities for collaborations with pediatricians that can help in some areas of postpartum care. We mentioned already that about half of maternal deaths occur postpartum, and lastly, this was really Haywood's major initiative back in 2017. So obviously the postpartum period is very complicated for women. There are multiple changes that are happening that we don't need to get into very much, but obviously there's physical recoverment. There are hormonal changes that are happening pretty quickly that can affect people's health as well. For new moms, especially for first-time moms, learning to take care of a newborn, if you already have kids, trying to balance the care of all of the other kids as well with your partner and family. A lot of challenges: sleep, pain, difficulties with breastfeeding, stress. Again, perhaps exacerbation or new onset mental health issues such as postpartum depression, sexual desire changes, and incontinence all make the postpartum period a very complicated time for a woman and for her family. So in the document that Pat referenced, it's called Optimizing Postpartum Care. It's a committee opinion. It really talks about a new sort of paradigm for how we should be taking care of patients postpartum. And I would add that there's actually a great ACOG postpartum toolkit that's available on the website that really has a lot of great information and a lot of great references to documents from ACOG and elsewhere that I think will really be helpful to you as you're thinking about your patients either in the hospital or in your practice. So again, the overarching principle of this sort of redefined postpartum care paradigm is that it's not the end of a medical event, but rather we should view it as the beginning of the rest of a woman's life and a chance to really help them achieve great and improved health. It should be an ongoing process and not just that single 6-week visit that is just very focused on a couple of medical issues. I think I heard someone talking about being patient-centered. That certainly should be a focus of all of us today, to really sort of focus on the individual. People have individual needs, and we need to really pay attention to that. So ideally, in this new model, there would be some contact with the woman at the minimum within the first 3 weeks after delivery. How you do that, I think, can be very individualized. For some patients, that could be a visit, that could be a phone call, that could be having your nurse text or email with the patient. There are a lot of ways, or using your EMR communication system to do that. But some sort of assessment or sort of check-in with a patient at the minimum in the first 3 weeks. And that's new for us. So we don't really, at least we had not traditionally done that. Ongoing care is needed, and then a comprehensive visit no later than 12 weeks post-delivery. And all of those 3 pieces should be individualized. So a patient that you touch base with at 3 weeks may need something between then and when she comes back for her comprehensive visit. And we're going to talk a fair amount about the components of the comprehensive visit in just a couple of minutes. And this slide really sort of points out the old and the new. If you look down at the bottom of the graph, and this is right out of the committee opinion, at the bottom of this is sort of our old model of postpartum care, which essentially is a 6-week postpartum visit for every single woman. It doesn't matter if she had preeclampsia with severe features and choreo and an infection and a PE and was in the hospital for 5 days, or if it's her 3rd baby and she had an uncomplicated vaginal delivery and went home. That's the old model, and even just saying that sounds sort of like a silly plan. And we need to move on from that to what we have up on the top, which is really that focus on an initial contact within the first 3 weeks of delivery, and then ongoing follow-up and a comprehensive visit somewhere between 4 and 12 weeks after delivery. The other piece that we're going to touch on very briefly is what to do with patients with hypertensive disorders of pregnancy. They probably need a little bit closer follow-up than most patients, and we'll talk about that a little bit as well. So one problem that I think we've had traditionally is the fact that a lot of patients didn't come for their postpartum visit. And it's easy to point a finger at the patient, but I actually would turn that finger around and point at ourselves. Patients probably weren't as compliant as we like because there wasn't value for them, other than, again, talking about contraception, and there's much more to it than that. And just look at some of the data. About 80% of women who have commercial insurance actually attend their postpartum visit. 50% of Medicaid patients will come for a postpartum visit. This is some national data. But unfortunately, for the patients who probably need it most, who are the patients who are uninsured or self-pay, we don't really have any data on them, but I am sure that it's much, much lower. The net result of all of that is that we really don't do a great job in helping women be set up for success for their health, and we can do a lot better. What are the reasons for poor attendance? I think there are probably many, and some of these are, I think, opportunities for us to think outside the box about sort of changing how we take care of patients and how we give them access to us as providers. But certainly it can be very inconvenient for a new mom and for a new family. They have lots of competing priorities. I think that 3rd bullet point is really important. They're not sure why they're coming in. It could be like a 2-minute visit, and yeah, that's a waste of time to get in a car and drive for 25 minutes if your doc is just going to say, hey, how are you feeling? Good, you're breastfeeding, no contraception, see you later. That's not a value-added proposition. So we need to do a lot better than that, and I think talking to patients in the prenatal period or in their delivery hospitalization about the purpose of a postpartum visit might help to do that. Previous poor experience with the visit, I think that goes without saying. There can be some bad things that happen that sort of stress people out, that make them not want to see their provider if they had some difficult birth experience. People don't like to be scolded, and one of the things that I think patients can sort of feel scolded about sometimes is breastfeeding decisions, so I think we need to encourage them, but if they decide to go in the other direction, that's probably not very helpful. In big practices, sometimes patients can feel disconnected with their provider. If you have a big group practice of 20 people, they don't know who they're going to be seeing. It might be disincentive as well. And then again, the sort of framing issue, as I alluded to early, it's not the end of a healthcare event, it's rather the beginning. So I think things that we can be doing to try to help with that, or to really discuss some of the issues that we're going to be focusing on postpartum in the prenatal period. Now, I don't think that means that we need to be beating people up constantly about what they're going to do for contraception after delivery, which I think was discussed a little bit in the last session. But I do think there are things that we should be trying to check in with patients about, even before their delivery hospitalization, just so that they are aware of the kind of things that we're going to be thinking about. Infant feeding, baby blues and emotional health, challenges of parenting, sort of what are some of the postpartum recovery things that are going to come up, long-term management of chronic health conditions that we'll talk about in a bit, and a little bit about pain management, especially now in the days of the issues that we're having with the opioid epidemic. And I think, trying to sort of check some of these off during the prenatal period will really help moms to think about the importance of their postpartum visit, and hopefully will stimulate a lot of questions from them as well when they come in for that comprehensive visit. So obviously, we have an opportunity to check in with moms after delivery as well. It's a little bit of a tough time, I think, to have a lot of big discussion. They've got a brand new baby, hopefully in the room with them. They've got a lot of family sort of hovering about. But I think there are some things that we can try to check in with patients about. So I think first is what the postpartum care plan is going to look like. And I think a really important thing is patients need to know who to contact. They need to have sort of a contact number for a doctor's office, or if you have a sort of call center line that's staffed by nurses to talk about postpartum concerns. But they absolutely need to have a point of contact. I think another really important issue is, and again, I sort of alluded to this earlier, is what to do with patients with hypertensive disorders of pregnancy. They sort of fall into their own category. I don't know, for those of you who are clinically focused in the audience, if you're seeing as many postpartum readmissions for preeclampsia as we are. I feel like it's almost an epidemic, and something that is just really sort of bogging down our system. And I think part of that is because we don't do a great job managing people's hypertension related to preeclampsia after delivery. So again, I think it's really going to be important to check in with those patients a lot sooner. And this, again, comes right from that ACOG document. So again, for patients who have a hypertensive disorder of pregnancy, you need to be seen or checked in with somehow, perhaps a home visit if your patients have access to that, within 7 to 10 days. And for your patients who have severe hypertension, preeclampsia with severe features, if they required IV meds while they're in the hospital, we should be trying to see them probably physically within 72 hours. So that's a little bit of a different group. So most patients can be sort of checked in with at about 3 weeks. Again, most patients. But we want to see our hypertensives a little bit earlier to hopefully try to manage their hypertension better, hopefully reduce some of the complications that come with hypertension, and hopefully reduce some postpartum admissions for hypertensive disorders. And again, how do we define what a visit is? Again, I think it could be a lot of things. I think office visits are fine if it's convenient for patients. Home health care is great. We have a couple of practice nurses who work in our MFM practice who develop very close relationships to our patients. They'll check in by text and email and all sorts of different communications strategies. Hopefully not Facebook or Instagram, but so I think there's a lot of different ways you can be clever and accomplish that. And I think we touched base on that. All right, so let's talk about the comprehensive well woman visit. Again, we're going to see our hypertensive quickly. All other women should have some contact in about 3 weeks. And then we're going to have really a comprehensive well woman visit that's going to set women up for success in their health, hopefully in the long term. And that should really be a transition point to well woman care. And ideally, we're going to do that between 4 and 12 weeks postpartum. So we're going to go through these like in a little bit of detail, but hopefully not too painful, because I know you're all very aware of this. But this is, by and large, the list that you will see that comes out of the ACOG toolkit for this. So here are a list of things that are potential discussion items during a comprehensive visit. Immunizations, incontinence, pain and sexual function, breastfeeding, reproductive life planning and contraception that I think was discussed very, very well in our last session, depression screening, intimate partner violence, substance abuse, weight and exercise, chronic medical problems, and perhaps a little bit about the management of future pregnancies. So that's a big list. Like, I look at this list and I think about, what I mentioned before when I was a resident, pap smear and contraception. This is a lot more for us to cover, but I think there are some clever ways that we can do it. So we're just going to sort of do one or two slides on each of these just to sort of go over what some of the most salient issues are. So for immunizations, again, it's a great opportunity to sort of review where we are. Immunizations are really important and beneficial to the health of our populations. Again, one of the major foci should be Tdap. Hopefully most of our moms are getting Tdap in the third trimester, really focused on the prevention of pertussis in kids. We also want to try to make sure that families know that all household contacts of the new child and caregivers should also get Tdap. We don't have a great mechanism to give them Tdap in the office, but fortunately you can go to Walgreens or CVS or whatever your local pharmacy is and do it that way if needed. In terms of safety of vaccines, they're all really fine except for smallpox, sort of any live virus you generally try to avoid, but they're really all fine. People should be vaccinated for the flu as well if they haven't been already vaccinated in flu season. But again, there's a great document, comes from the CDC. It's updated very often on the college website to go over what vaccines are recommended for women, and it's a great time to review that and to make sure that people are up to date. Incontinence, I think, is something that is sort of an uncomfortable topic in a lot of ways, but it's really common, and I think we can do a lot better than when we currently do. So there's urinary and fecal incontinence. Urinary incontinence is pretty common. About almost 20 to 40% of women will have some degree of urinary incontinence postpartum. Fortunately, a lot of it resolves sort of spontaneously when there is less inflammation and there's more healing in the area after delivery. But about 10% persists beyond 3 to 6 months. So that's a pretty appreciable fraction of women who are having incontinence. Risk factors, I think many know these risk factors, but vaginal delivery, having a long second stage, older age, increased parity, macrosomia as well are risk factors. And I think that it's something that we should be mentioning to patients and perhaps screening them when they come in. But again, we have to sort of make the effort to ask those questions. Again, we don't need to talk much about diagnosis and treatment, but I think that you're not going to make a diagnosis and recommend treatment unless you ask. And I think that's true for a lot of the things that we're talking about today. At WashU, we decided to actually, that doesn't show up very well, but we actually have a little screening form that we use for our patients. For all of our postpartum patients. This is, again, at their comprehensive visit. This comes from the Pelvic Floor Disorders Network. This is how they screen for incontinence in research studies. It's a very simple series of questions. If anyone answers yes to any of those, then that sort of triggers a more thorough assessment and questioning about what's happening. So again, we decided to do it this way, probably because it helps us to remember a little bit. It's sometimes easy in sort of a busy office session where you have expectations for high productivity to forget things, and this is just a little bit of a trigger for us to try to remember. Fecal incontinence is less common, but is really obviously very concerning. Incidence is a little bit higher than you might think. It's about 10% in postpartum patients. The OASIS is for obstetric anal sphincter injuries. Those occur in about 18% of vaginal deliveries, and that is strongly associated with the development of incontinence. Risk factors are similar to urinary incontinence, in addition forceps deliveries, and I think that just the bottom line is we have to ask the question. Again, it's something that's a little bit uncomfortable to ask or to talk about, but we need to be sort of fearless when we're talking to our patients, and that's what they expect, and that's what they should, and that's what they want. So I think we just need to ask. Again, we don't need to get into the diagnosis and the differential, but suffice it to say there could be an injury to the perineum that needs to be repaired. People can develop fistulas after delivery. There are a lot of things that we need to be aware of. But again, you're not going to find those things if we don't ask, so we have to ask. And again, we don't have a screening form for this kind of incontinence. I think it's really sort of a one question or two question kind of thing to bring up. Pain, dyspareunia, and sexual function. Again, a lot of women have a lot of pain after delivery that lasts for a long time. Up to 17 to 20% of women have that kind of pain 6 months after delivery. And again, it's a question that we need to ask. Are you having pain with intercourse? And again, a yes response to that should really trigger additional questioning. It should trigger a physical exam. It should trigger sort of looking for causes that we might be able to hopefully improve. Breastfeeding, I would imagine there was some discussion about this in a few sessions today. Again, we don't need to belabor the point too much, but suffice it to say there are incredible health benefits to breastfeeding, and we should all be trying to support our women and encouraging them to breastfeed. And I know that everyone here in this room is is on board with that. We're doing better. About 81% of women in the U.S. at least begin breastfeeding, and about 50% are breastfeeding at about 6 months. So that's much better than we had done in the past. And I wouldn't say our place is doing quite that well. We were recently designated as baby friendly, and that's sort of really helping us to work on that. But again, I do think it's really important. And I think it's important to sort of bring this up at the comprehensive visit to really talk about how breastfeeding is going. And are there issues, and are there resources or things that we can do to help? I think before women start to breastfeed, a very common question, especially for us at MFM, is the medication that I'm taking for my seizure disorder or for my history of a thrombosis safe to take when I'm breastfeeding? And I have a hard time remembering all of those medications, even though I see those patients all the time. I would really encourage you all to grab this app called LactMed. You can just go right to the App Store on your iPhone. I assume it's on the Android store as well. It's really great. You can type in just the generic name or the other name for the drug, and it'll tell you exactly what you need to know that moment for taking care of a patient. I'm not going to talk about contraception because I think the last session really covered that very well with breastfeeding. I would just encourage us all to use lactation consultants liberally, but also, again, this came up in the last session, let's try to make sure we're sort of on the same page with them, because you can definitely get into differences of opinion about different medications to help with breastfeeding and what's the role of estrogen and decreasing breast milk production. And I think to the extent that you can, we want to be on the same page. The worst thing is for patients to get mixed messages about what they should be doing with their health. And I've had that happen a number of times, and they're easily resolved with some face-to-face conversations with other healthcare providers. But again, I would say use your lactation consultants liberally. In fact, in our MFM practice, 2 of our nurses who work for us actually are formal lactation consultants and really help us day to day with that. This came up also in last session. It's really important at this comprehensive visit to talk about the future and what are someone's sort of perhaps short, mid, and longer term goals for their family size. And I know we talked about that one key question, which I think is really great. Would you like to become pregnant in the next year? I think our last speaker talked about perhaps extending that out, which I think is terrific. That will really sort of set up a good segue into a discussion about different contraceptive methods, which I think have been covered really well. And a little bit about pregnancy interval as well, which is a really important and somewhat under-discussed topic, I think. I'm going to skip that. And I wanted to just show just a little bit of data. I only have a couple of data slides, but this really looks at all of the studies sort of summed up, looking at the relationship between birth spacing and the risk of adverse perinatal outcomes. And this was published in JAMA. This is an older study, but I think still is probably the best out there. It took 67 different studies and sort of put them together, looking at that relationship between the time between pregnancies and, or actually deliveries, rather, and the risk of increased bad outcomes. And you can see for interpregnancy intervals that are less than 6 months, there's an increased risk for almost everything bad that you can imagine. Preterm birth, low birth weight, IUGR, or small for gestational age, and that there was still a risk between 6 and 18 months as well, although the risks were a little bit smaller. So I think avoiding less than 6 months is a good idea. Now, interestingly, there was also an association between interpregnancy interval, and some of those outcomes if it was very long as well. That's a little bit complicated because there's probably a lot of reasons why the IPI might be long, might be related to a lot of other health issues that a woman might have. But I think suffice it to say the best information we currently have is that the ideal interpregnancy interval is between 18 and 59 months in terms of having an ideal perinatal outcome in the next pregnancy. Just so you know, the way this is being counted, that 18 months means having a conception 9 months after your last delivery. So it's actually from delivery to delivery, if that makes sense. So again, I think birth spacing is important. I think Stacy Stewart is talking tomorrow from March of Dimes. March of Dimes is really looking for some of the things that we can do to impact preterm birth, and interpregnancy interval is one of the very few modifiable risk factors to reduce the risk of preterm birth. So again, something really important, I think, to talk about. Postpartum depression, again, I think we all know a lot about this already, but screening for postpartum depression, I think, is very important, is very common, 11 to 20%. Again, risk factors, I think we probably have a pretty good sense of, but prior history of depression, anxiety, stressful events during the pregnancy, preterm birth, or a baby in the NICU or intensive care nursery, sort of low family social support, and issues with breastfeeding are all risk factors. I think we finally come to a place, I guess probably about 6 or 7 years ago, where ACOG recommended that all women be formally screened for depression. Not just how are you feeling, but actually using a scale that is validated in pregnant women to screen them. And if you go to this postpartum toolkit, or if you go to the ACOG committee opinion on postpartum depression, they have a list of validated tools. Validated means that they've been researched in that population, and they know that they are screening for what we want them to be screening for. The most common one is EPDS, Edinburgh Postnatal Depression Scale. It's what we use. We actually have it computerized on a little iPad for patients, so when they come into our waiting room, we give them an iPad, and they sort of click through that and calculates the score to us, which is pretty simple. It's like only goes up to 16, but it helps us. So I think you need to be using a validated tool. We've actually started screening a number of times in pregnancy. So we screen at about 24 weeks. We screen when a patient is in the hospital after delivery, and then we screen them at their comprehensive visit as well. And I think there's a lot of benefit to that. Treatment, I think, is, it could be multifactorial. It depends where you are and what kind of availability you have for other specialists, but peer counseling, cognitive therapy, antidepressants. I would say when this committee opinion on postpartum depression came out, I was on that committee at ACOG at the time, and as we were writing it, it was clearly the right thing to do, and my initial reaction was, wow, we're going to make all of these diagnoses of depression, and we have no place to send the patients. Like, nobody's going to see them. There aren't enough people doing therapy to take care of them, and I think that really did sort of force our hand as providers to become more comfortable in using antidepressants ourselves, although I still don't feel totally great about it. I feel good enough to prescribe and get people started, but I do think trying to develop some relationships with health providers, mental health providers in your community is going to be really important, because you're going to turn up a lot of positives. But again, I think the key thing about postpartum depression is use a validated tool. Pick one. Use it. It doesn't have to be EPDS, although I think that's the most common around the country. I wanted to mention this just as there are some things that we do extremely poorly where I am, and there are some things that we do pretty well. This is one of the things that I think we actually do pretty well. We actually have a health service, a perinatal behavioral health service at WashU. I guess it developed about 8 or 9 years ago and was really the genesis of a pediatric psychiatrist, and as well as some faculty members in my department, who really felt like we were doing a poor job in sort of the mental health needs of our women who were pregnant and had complicated pregnancies. So sort of a group of people got together that included OBs and psychiatry, psychology, social work, and started with moms and families in the NICU. So again, moms who have sick babies in the NICU are at very high risk for a lot of mental health problems. And this group would go and visit with them a couple of times a week. They prescribed meds for depression, and they really, I think, provided a great service. We then extended that program to our high-risk undelivered patients. A lot of those are moms who have babies that we know have birth defects and are going through a very difficult pregnancy with a lot of uncertainty about how things are going to turn out. That was really successful as well, and we expanded that to really seeing all of our pregnant patients in the hospital after delivery, and then if we think that they need to be seen before delivery, this group sees them as well. They either talk to patients on the phone, they do in-person visits,